Thank you to Virtual Pathology at the University of Leeds for this liver biopsy case. I'm coming from a general pathologist point of view. If I received this case, I would want as much history as possible, including imaging, any medications, viral serology, labs, prior liver biopsy results, what the FibroScan or ultrasound of the liver showed, prior medical, surgical history. And so for this case, this 45-year-old female, she has raised ALT 187, raised IgG of 26.6, ANA is positive, suggesting an autoimmune element. She has been previously on treatment for breast cancer in 2020, including tamoxifen, which has been shown to lead to macrovesicular steatosis of the liver. Alk Phos is 125, bilirubin 7, albumin 34. And here's a liver core biopsy. So what I find challenging about liver is that there is no definitive diagnosis. You have to take into consideration your clinical history. So from this liver biopsy, I can see the capsule here, and I see a lot of cellular infiltrate in the portal tracts, or zone 3, and here's zone 1, and some trickling in zone 2. So that's my first impression. And with that, a lot of cellular infiltrate that can be seen in like chronic hepatitis, primary biliary cholangitis, as well as autoimmune hepatitis, maybe an element of steatohepatitis. So let's go closer. So here's the bile duct. That's primarily unaffected. This would be attacked in primary biliary cholangitis. The cell population is predominantly lymphocytic as well as plasmacytic, so lymphoplasmacytic. There's an element of steatohepatitis here with some balloon cells where the cells kind of balloon up and round up. The way one of my attendings had explained this to me is, in just a simplified view, is fat leads to inflammation. Inflammation injures the hepatocytes. That injures the cytoskeleton, which is the skeleton of the cell, and that skeleton gets injured more and more, and so that cytoskeleton is dysfunctional, and that's why it balloons up. So this is steatohepatitis. It's a type of MAFLD, or metabolic associated fatty liver disease. Another type is steatosis, where you just have fat buildup in the liver without this balloon cells. So we have an element of steatohepatitis. So this is a good example of interface hepatitis, where the lymphoplasmacytic infiltration expands beyond the portal tract and kind of envelops, as you can see, envelops the hepatocytes here. So that's a good case of interface hepatitis, which can be seen in autoimmune hepatitis. Here's a good ballooning degeneration and some possible Mallory-Denk bodies here. So this was a case consistent with an element of steatohepatitis as well as autoimmune hepatitis. The tricky thing for me about liver is I feel like you only suggest that this could be the case, like steatohepatitis or autoimmune hepatitis, and you really need the clinical correlation as well. Here's a acidophil body, which is non-specific but can be seen in autoimmune hepatitis, among other entities. I would want serology to rule out any chronic Hep B, Hep C infection. I don't think it's PBC. I would want a antimitochondrial just to confirm. I don't think it's PBC because the bile ducts aren't being attacked in and of itself. There's no florid duct lesion. The Alk Phos wasn't too elevated. So I think with the history of the ANA, I'd like an anti-smooth muscle too, just to confirm or increase my suspicions that this is autoimmune hepatitis, as well as an element of steatohepatitis as well. So I hope this helps from giving it, just explaining this from like a general pathologist point of view.